Endodontics is the bread and butter of dentistry. We all have been doing it for years together with practically good longevity and practically good success rates. Then why are we here today? Why do we have these continuing development programs each day? Why do we have so many developments in the field of endodontic irrigants, endodontic files each day? Because no matter how long our RCT persists, or no matter what is the longevity of the tooth that we have treated, we being clinicians, we being knowledgeable dentists, we all know that root canals like this, which survive fairly well in the mouths for long years, have the potential to have been treated like this. But the reason why all those RCTs which were not done so well, which were probably not obturated till the apex, or which were not cleaned in the right protocol, survived for those long. And the reason, as rightly mentioned by Ray and Trope, is that the coronal seal is considered to be more important than the apical seal when it comes to the success or the longevity of a root canal restored teeth. So eventually such root canals fail and they come to us for retreatments. These are certain cases which have been retreated to make the root canals look better, work better. So is there any secret formula for successful endodontics? Alas, there is no magic wand. It's a complete combination of all these things. Most importantly, in my view, right tools and right materials. So today we are going to talk about the tools that are available in the dental market today, which help us in providing a good endodontic work. No matter which tools we use, I agree that the hands behind the tools is very important. But technology, when combined with biology, will indeed yield the best results. So the process of an effective endodontic therapy involves all these steps: a profound local anesthesia, isolation with a rubber dam. Remember, it is mandatory to isolate with the rubber dam when you are doing any endodontic treatment. A good access, working line determination, reproducing a glide path, shaping and cleaning, use of intracanal medicaments whenever necessary, obturation, and a good post-endodontic restoration. We'll discuss the major points one by one. To begin with, we talk about access. We all have read this, that access is success. Access being the most important and the first step in endodontic treatment has to be done very carefully. It has to be given the maximum time in your endodontic treatment so that rest of the part of the root canal becomes very easy. Once you have a good access, your irrigation, shaping, cleaning and obturation will be done in no time. In my practice, I spend most of the time doing a good access, and then everything else is a cakewalk, believe me. So what are the objectives of an access cavity preparation? First and foremost objective is to penetrate the occlusal surface of the pulp chamber and de-roof it completely. When I say de-roof it completely, that means you are not supposed to shape and clean the canals through the punctures made in the tooth. If you do so, there will be some amount of organic matter left in the chamber and which will eventually cause failure of the tooth. So you have to penetrate it and completely unroof the pulp chamber, obtain uniform contact of the file with the access cavity wall, which will be coming in the future slides, and then obtain a straight line access to the point of first curvature or the apex, whichever possible. So this is what I meant by removing the roof completely. These punctures made through the pulp chamber are not the pulp chamber. In fact, you have to remove this part as well, and you will see a dentinal map. These are the two orifices which are being connected by a fin or an isthmus. So As I told earlier, multiple punctures, they are not canals. Once you completely unroof the pulp chamber, you will see what is known as dentinal map. This dentinal map is unmistakable dark fissured chamber floor, and you'll see that this road map will lead you to the canal entrances. This is why the role of magnification. With magnification, you can see this dentinal map very, very clearly. And with the help of a DG16 probe, you can just follow this dentinal map and you will dig into the canal. And once you enter the pulp chamber, you have de-roofed the pulp chamber completely. You have to obtain a reproducible glide path. Now, why this glide path? We all know that all the rotary files available in the dental market have non-cutting tips. These are not meant to negotiate the initial curvatures of the canal. So we need a stainless steel K file, preferably a 10-number stainless steel K file to negotiate the canal initially and develop a pilot path for all other files to follow. So this is a smooth reproducible passage of stainless steel files without any obstructions from the oil files till the apex. Coming to the individual axis cavities, very basics we'll go through. Maxillary central incisor, it would be an oval triangle. What you need to remember here is that when you open up an axis cavity in maxillary anterior tooth, then there is this lingual triangle here which interferes with the straight line axis of a 10-number K5 or 20-number K5. Why does it do so? Since this lingual triangle is interfering with the straight line axis, what we have to do is, once we realize where the constriction is, we have to take a long neck round carbide bud or an EX24 bud, that is a long tapered fissure with a safe end, to remove this lingual overhang. And you can see here, now the file has a straight line axis. So what is the advantage of doing this? Once you remove the corneal hindrances, then not only your rest of the work becomes easier, your file is not stretched anywhere into the canal like it was being before. So life of the files is increased, fracture liability is decreased, and we can go ahead with the next procedure very easily. Coming to mandibular central incisors, these will more often have two canals. So in 30% of the cases in mandibular central incisor and lateral incisor, almost 44% of the cases they will have two canals. And which canal do you often miss? We all have read this concept, learned this concept that if you enter from buccal, you end up in lingual. When you enter from lingual, you end up in buccal. So if you make an axis cavity from the lingual side, then there are high chances of missing the lingual canal. So in mandibular anteriors, it is preferred that we prepare an axis into the incisor ledge. When you do so, you will not end up missing the lingual canal as well. So you will have two canals most of the times, like this. Talking about maxillary premolar, first one, two canals, parallelogram axis opening, and the mandibular premolars. Very often with mandibular premolars, you come across with X-rays like this. The disappearing root canal. It's an indication that the canal is dividing in 2 or 3. It's bifurcating at some point where it does disappear. So how to treat such cases? Very easy, don't get panicked. Just extend your axis till that area of furcation with a long tapered fissure safe-ended burr. And from here you can consider it to be two canal tooth. So from here you prepare these two canals separately, obturate them, and then rest of the canal can either be filled with a thermoplasticized gutta-perca, or you can make a corno-radicular restoration with a composite here. Talking about maxillary canine, oval shaped axis openings, most of the times one canal, no worries. Coming to molars. This is the maxillary molar where we used to make a rounded triangle opening earlier. But now, since we know that most of the cases will have an MB2, so it has to be extended in the mesio-buccal direction to incorporate the MB2 in the axis opening. Also, this mesial side has to be flared so that your MB2 is easily visible somewhere here. I'll give you certain tips and tricks on finding MB2 in the later half of the lecture. Next, we talk about lower molar. The opening has to be quadrilateral. It is to be the mesial two-third of the tooth. Somewhere here we start. Also, you must remember before starting with your access opening that you have to assess the occlusal and external form of the tooth before you begin. Because you are supposed to be perpendicular to the long axis of tooth, not perpendicular to your maxilla or mandible or your patient's position, whatever it is. So make sure that you assess it very well so that you do not end up perforating. Now, Kressner and Rancourt have given some laws on orifice location. When I used to read these laws during my undergrads, I used to find them very boring. It was very difficult to remember 6, 7 laws all together and write it down in the exams. But if you think practically, if you start implementing into your practice, these are amazing, believe me. So we'll talk about them one by one. First and second law of symmetry. First thing to know is that maxillary molars will not follow these laws. So it is for all other teeth. So first law of symmetry says that if this is a floor of pulp chamber, consider this to be a floor of pulp chamber. If I draw a line in the center of this floor of pulp chamber from mesial to distal direction, this is a line that I've drawn from mesial to distal direction. So my pulp chamber orifices are going to be equidistant from this line. So this is the first law of orifice location by Kressner and Rancourt. The second law says that this canal orifices will lie on a line perpendicular to the line that we had drawn first. So this is a pulp chamber. If we draw a line in the mesiodistal direction, a line perpendicular to it, the orifices have to be equidistant from this line. So what is the importance of this? The importance lies while you are locating the distal canals of lower molars, for example. Often interns will come to us and they'll ask us, "Ma'am, इसमें एक canal है या दो है? Please check करके बताइए." You can do it yourself. How? If you can find 2 canals on the mesial side, mesiobuccal, mesiolingual, look at the opposite side. In that center line, which is dividing the pulp chamber mesiodistally, if you find a canal on the distal side on that particular line, that means there is only one canal. If it is either buccal or lingual to that particular line, that means there has to be another canal. So please extend your pulp chamber, please extend your cavity to find that other canal. Got it? So we are going to go to the third law now. Third law is the law of color change. It is again of enormous help for the beginners, as a lot of times when you begin with the root canals and you're very scared that you might end up perforating, you'll just go to the DEJ, remove some dentine and wonder if the canal is calcified, if the pulp chamber is calcified. How do we distinguish? Floor of the pulp chamber is always darker in the color than the walls. So that gives you a clue. If you are into the pulp, floor will be always darker than the walls. While if you are into the dentine, dentine will have same color whether it is floor or the walls. So remember that. Coming to next 3 laws of orifice location. One says that orifices are at the junction of wall and the floor of the pulp chamber. If this is the wall and this is the floor of the pulp chamber, it has to be here at the junction. The other says nothing, just a twist in terminology. It says it is at the angle of junction of the junction of floor and wall. Okay. And the third one says that it is located at the terminus of roots developmental fusion lines. So how do we interpret and implement such things in our practice? When we prepare an access cavity preparation, especially for postgraduates, when examiners come and examine your postgrad exam access cavity, they say that you should not have overextended the cavity. It should be just enough to allow you to have a good shaping, cleaning and obturation, but it should not be extended too much, compromising on the strength of the tooth. So your orifices should lie at the junction of wall and the floor. Now why so? How does it help? It makes the entry of the file into the root canal orifice much easier. Consider this to be a room and there is one container, one dustbin kept at that corner. If I make a paper ball and if I want to throw it there, it is easy for me to throw the ball there if it's kept at the corner. If I slide it somewhere closer, the chances that I will be able to throw the ball exactly into the container are lessened. Similarly is the principle in carom board, because those holes that are there, these are at the junction of the wall and the floor. It is easy for the pebbles to get in there. So this particular law makes it easier for you to use your files even if you cannot see at times. When as beginners you are practicing on upper second molars, lower second molars, you can just use your tactile sensation and this basic common sense and insert the file into the canal. Coming to maxillary first molar, here the trick is in finding the MB2. So how do we search for MB2? Firstly, why these canals are so tough to find? What is so big fuss about MB2? Number one, we do not use magnification a lot of times. Especially with the beginners, we are not using magnification. And then we say that we have missed MB2. These are rarely visible on initial axis. Initial axis is generally rounded triangle. So you ought to miss it, there is no doubt about it. So what you do is that you should visualize the most likely location and then extend your axis slightly mesially, flare the mesial wall to locate the MB2. There is this T rule to find MB2. We have to make a T. The long arm of the T is between mesio-buccal and palatal. And the short arm is perpendicular to it, joining the distobuccal. Now if you cross the T and go towards mesial, you find what is known as MB2. Did you get that? It's the T formed by the three canals which we negotiate early in any maxillary molar. You just have to cross that T, go straight and you find MB2. So MB2 is often in level with distobuccal. You can see here mesio-buccal 1, mesio-buccal 2, distobuccal. So this is in level with distobuccal and is generally equidistant from the palatal, as you can see here. Coming to the working length, as determined by the studies by Cutler, there are two diameters at the apical end of the tooth. One is minor apical diameter, the other one is major apical diameter. So we all need to know that we are supposed to obturate to minor apical diameter and not the major apical diameter. This is why electronic apex locators are important. When you obturate to the radiographic terminus, it is the major apical diameter which you are obturating to. And when you do so, it is often overfilled. So the idea here is to use an electronic apex locator and obturate here at the minor apical diameter. So there are various techniques for working length determination, namely tactile, radiographic, electronic, paper point. We'll talk about them in brief one by one. Number one is tactile. I call it sadistic approach. Open the tooth pulp chamber, put the canal, put the file into the canal and ask the patient, "Dard ho raha hai? Dard hua? Dard hua? Hua." So this is a sadistic approach of determining whether the apex has been reached or not. So not indicated. Coming to radiographic, as we spoke earlier, radiographic is a method that has to be used even if you are using an electronic apex locator, but it is not the sole method that will determine the working length, because it gives you radiographic terminus, and the studies by Cutler have shown that radiographic terminus and anatomic terminus are two different sites. There could be as much as 3 millimeters of a difference in that. Coming to electronic method. Electronic method is the use of electronic apex locators. Now, as I told you earlier that the hands behind the tools are very, very important. So even with an electronic apex locator, you might not be able to find the apex correctly. So there has to be a correct way of using that apex locator. So you need to know certain things about the apex locators that we use these days. These are impedance-based apex locators, and they give you readings like in negative when you're short of the apical foramen, or in positive when you have exceeded the apical foramen, and it comes to 0 when you're exactly at the apex. What you need to remember is, number one, never stop short or beyond the apex and say, okay, I'm 1 millimeter short of the apex, this is 18, so the working length has to be 19, alright, assistant can remove the apex locator. No, because the reading is not in terms of literally millimeters there. it is in some form of x. So you don't know what 1x is or what 2x is. So you have to reach 0, and that reading has to be your working length reading. So remember that, 1 point. Next, when you're using an apex locator, your root canal chamber should be dry, but your canals have to be wet. How do you do that? So once you have used your pre-flaring, once you have pre-flared your tooth with either gate slit and drill, or we have coronal orifice shapers for that. If you do that, after that you have to determine working length. So use saline, normal saline, irrigate the tooth, use a small cotton pallet to dry the pulp chamber, and let the canals remain wet. And then you can place a 10 number K file in a watch binding motion into the tooth, take the clip of the apex locator, put it there, and measure the working length. Make sure that you do not contact any metallic restorations when you are doing so. If there is a metallic restoration, I would suggest remove it, because anyways you have to make a permanent restoration after you complete the root canal. And if you cannot remove it at that time, at least make sure that the walls are flared enough so that it does not touch the metal. Otherwise there would be error in the reading. Last but not the least, paper point method. I love this method. But the only and the biggest drawback with this method is that you cannot use it before your shaping and cleaning. You cannot determine the working length with the paper point method unless you have shaped it. But it serves as a good check after you have prepared the canal, cleaned the canal, want to obturate it. So anyways you are going to use your absorbent paper points to dry the canal. But when you do that, if you get some tinge of blood in that, that means you have overextended. That is the time you can make a correction. So it is a good recheck for the working length that was determined at the prior location. Coming to the major aspect of it, shaping and cleaning. You all know that all the endodontics aims at killing the bacteria, or at least removing them, so that you can treat or prevent apical periodontitis. So shaping and cleaning plays an important role, but remember, we shape to clean, we don't clean to shape. So shaping is very, very important, and then the rest of the work is done by the irrigants. Now these days we all talk about crown down and greater tapers. Why? Why not step back? Crown down facilitates better preparations with minimal apical debris extrusion. When patient reports to us for a root canal treatment, it always commences with pain. More often, sometimes there will be swelling, but generally it is pain, the biggest complaint in dentistry. So you don't want to give more pain to the patient. When there is apical debris extrusion, patient will have some kind of pain. It will have an impact on post-operative healing and post-operative pain. So with the crown down technique, what happens is, since you have enlarged the corneal area before going to the apex, you have created a reservoir, a space for the apical debris to come out. You are not packing debris into the canal. So there is less of inflammation, less of post-operative pain. It also gives a proper funnel shape preparation as per the Schneiderian principle, which is very easy to pack. Also, it increases the irrigant penetration into the apical third. There are some misconceptions which need to be cleared out, that rotary files can do everything. No. Hand files are indispensable. You are not supposed to introduce the rotary files unless you have prepared your canal with at least 20 number K file. And for glide path, definitely you have to have a stainless steel K file. So rotary files cannot do everything. It is always a hybrid technique per se. They do need a learning curve, although the learning curve is not as large as we have for operating microscopes, but there is definitely a learning curve. Hand files are indispensable. They have to have been, they're supposed to be in your armamentarium. Rotary files last forever, or is there a magic number? Alas, there is no magic number. It can last one case, it can last 10 cases. So whichever company, whichever file claims that our file lasts for this many cases, it's a myth. It all depends on what kind of cases are you doing, how are you using your files. As we move towards demo and hands-on procedures, I'll tell you how the handpiece is supposed to be used. You're never supposed to push the canal, push the file into the canal. It is always a light pressure, feather touch. So there's no magic number. Every file has the potential to break. But owing to better technologies that are there in the market now, those fracture resistance have definitely increased. As we'll see in the studies that we will come across later, we have newer technologies now. Earlier, files used to be built by having a metal core, and cross sections used to be cut from them, which used to create certain micro cracks already in the file. So you have a file which already has micro cracks, and when you introduce it to the canal, where it undergoes compression, tension, it fractures. So now we have technologies wherein files are not prepared in these ways. They are rather prepared by electromachining discharge, wherein there are two electrodes and the deposition causes the manufacture of file. There is no point of microfracture into the file as such. Last and the most important myth that certain rotary is the best. How you use the rotary, how good you are as a clinician is more important than which system are you using. So too often the designs of these techniques are determined by marketing, where product promotion prevails over science. So today we are going to talk about science and not the product promotion. And then you have to decide for yourself which technology is better and which technology when combined with biology will yield us better results. What's important is the sequence and method of irrigation. Regarding method of irrigation, never force the irrigant into the canal unless it is normal saline. And that too when you want to give intrapulpal anesthesia. You know how intrapulpal anesthesia works? It only works because of pressure. It does not work because of LA. So whenever I have to do an intrapulpal anesthesia, I don't use LA at all. I'll just fill the syringe with saline, lock it into the canal and push it. And this process starts. So it is the pressure that works there. So that is the only place where you're allowed to lock the file into the canal. Anywhere else, no. So the needle should never be wedged into the canal so that it should allow backflow of the irrigant along with the debris. Now it has been proved that apical 5 mm is not flushed until it has been enlarged to size 30 and more often 40. So what do we do about it? We have to have some external measure so that this apical 5 mm, which actually contains a lot of accessory canals and a lot of organisms, a lot of microbial load there, it has to be clean. So what we do is we use something called as manual dynamic agitation, MDA. Now, manual dynamic agitation is with the gutta-percha point. There are other ways of doing it as well. One of them is using specific devices. When you introduce the irrigant into the canal, you can use one of these specific devices to make sure that your irrigant reaches all the parts of the root canal system. One of them is a canal brush by Rico. Why it deserves a special mention here is because you have a lot of periodontists sitting over here, and specifically in endo-perio lesions, which occur because of this endo-perio continuum of the apical and lateral portals and exits. If you use such brushes while irrigation, it will make sure that the microbial load in the lateral canals and the other portals is taken care of. So it can be either done with this or one of these expensive things, or after your entire protocol of shaping and cleaning is done, you can use your master gutta-percha for doing something known as manual dynamic agitation. What you have to do is, once your entire shaping and cleaning is done, use your regular protocol of irrigants into the root canal. Never mix any two irrigants. Saline is supposed to be there always in between the two irrigants, because mixing of two irrigants is bad. It will either form a precipitate or nullify the efficacy of the other. With manual dynamic agitation, what we do is, once we have introduced the irrigant into the pulp chamber, we take the master cone, put it in the canal and start agitating it. Do it for 1 minute each canal and your foot is taken care of. So the sequence for irrigation for routine and retreatment cases is more or less the same, except with the use of chlorhexidine. In retreatment cases, we'll always use chlorhexidine. Make sure that sodium hypochlorite should not be mixed with chlorhexidine. If you do so, it will form an orange-brown precipitate and it will hinder the rest of the process. So saline has always to be there. But also, there are a lot of people who have read the articles on chlorhexidine and they say we are using chlorhexidine for every case now. Now, there's a catch in that. Studies have shown that 2% chlorhexidine, which we use as an irrigant for retreatment, is more toxic to periapical cells than 5.25% hypochlorite. So use it only when it is required. Don't use it for every case. So hypochlorite has to be used definitely for all the cases, but CHX, 2% chlorhexidine, is for retreatment cases. Remember to use a 17% EDTA liquid before you obturate, because that will take care of the smear layer that you have created with your rotary instrumentation. Finally, dry the canals and obturate. The variety of sealers available in the dental market today, siloxane based are the new ones. Then there are calcium hydroxide based sealers, epoxy resin based sealers, and the older zinc oxide based sealers. The most prevalent and most commonly used ones today are called epoxy resin based sealers, but these have been in the market for so many years. There's one thing which has changed, which we have not been taught, because this is the recent finding. Earlier, when the resin sealers were introduced, we were told that the canal has to be absolutely dry before you place a resin based sealer. So what we used to do was place one paper point, take it out 2, take it out 3, take it out 4, absolutely dry, fine, obturate it now. Now it has been proved that even for resin based sealers to set, it should have some moisture in the canal. So I recommend, to save your time, save your money, and go ahead with the science, use only one paper point per canal. Put a paper point, let it be there for 1 minute, remove it, and that's enough. Even if the paper point is wet, this much moisture has to be there in the canal, and then you can use a resin based sealer. Coming to obturation, there are various methods of obturation: single cone, lateral compaction, softened gutta perca. That is altogether a different story. I'll just put a small overview of about apical puffs. To produce a puff is educated by properties of softened gutta perca. We often tend to mistake it for every case. So puff has to be formed only if you're using a softened gutta perca technique, because with softened gutta perca technique, when it sets, it is supposed to shrink, so that it will shrink and pull down tightly against the apex, and you get a filling like this. But if you want to create apical puffs with normal cases where you're using a single cone technique or lateral condensation technique, you are doing no good, but rather you are making the patient feel uncomfortable for a couple of days, because no matter which sealer you use, until and unless it is set, it will remain toxic. Although the things subside as the sealer down the peri-apex will resolve with time, will undergo resolution, but it is better to do puffs only in cases of softened gutta perca. Then there are some carrier-based obturation systems as well, which are not much in use today. The most commonly used ones are either single cone, lateral compaction, or the warm gutta perca techniques. And then the core build-up and endodontic restorative. Make sure that the core build-up that you do, as we have seen earlier, that coronal restoration plays a very, very important role in the long-term prognosis of the tooth. The coronal restoration has to be a dual cure composite build-up. No glass ionomers, no simple composites. Because once you have done the obturation, you are supposed to remove the 2 mm of gutta perca from the orifice level. And then you are supposed to place the composite over it. And if you are placing about 2 mm of composite into the root canal, no light is going to reach there and cure it. So you have to have a dual cure composite, which will take care of the curing hands. To conclude, we have to keep things simple. Don't run behind the technology. Just integrate the technology into the biology and see the results. Use basic equipment. Don't change for the sake of changing. Proper irrigants, proper sequence. And remember, you need to execute. All inventions are there, but unless and until you don't execute, you won't get success. Now, what is the purpose of orifice shaper? Orifice shaper is supposed to shape the coronal part of the canal, so that there are no hindrances in the coronal part. Once you remove the hindrances from the coronal part and make it straight, it is very easy to execute.